Hello, ladies and gentlemen. Hope you all are doing good and keeping safe. Warm greetings from Bondent Group. I'm Dr. Sonal Khanna, Clinical Education Manager. Bondent Group provides end-to-end dental practice solutions ranging from endodontic and orthodontic consumables to dental equipment like dental chairs, Cbct, loop, and microscopes. For more information on product range, please visit www.bondent.com. It is my pleasure and privilege to welcome each and every one of you as our esteemed participants for this webinar on the topic Cbct, Third Eye in Dentistry. To tell you in brief about our speaker for today, we have with us Dr. Khalid Ikram, who is a very reputed name in dental fraternity and is one of the pioneers in the specialty of dental radiology and digital dentistry worldwide. Welcome, Dr. Khalid.
Thank you very much. Welcome, Dr. Sonal. How are you?
All well, doctor. How are you?
I'm fine, and thank you for inviting me on behalf of Bondent for this webinar. It's a pleasure.
It's our pleasure, doctor.
To present such a presentation, and I hope that the audience will like the presentation and will get some knowledge and some scientific info more than before. Thank you very much.
Yes, sure. Yes, sure, doctor. So Dr. Khalid is an international speaker. He is the CEO of Ikram Imaging and Digital Dental Center. He's an OMS consultant and an ambassador of GDS in Egypt. He's also an assistant professor with master's and doctorate degree in oral and maxillofacial radiology and is EDS certified consultant in Egypt. Currently, he is serving as the director of Digital Dentistry Diploma and Diploma of Implant Dentistry held by the Egyptian Ministry of Health. Dr. Khalid was awarded as one of the top 100 dentists for the year 2021 by top100doc.com. Congratulations, Dr. Khalid. Congratulations for this achievement.
Thank you very much, Dr. Sonal. I really working hard on this. I'm working on education. I hope everybody can get the benefits from the updated information. And part of it, of course, is today. I have some hot topics today that I'm going to discuss. So I hope that the audience will keep following up the lecture through the presentation time. Thank you.
Yes, doctor. Thank you, Dr. Khalid, for joining us. It's an absolute pleasure to have you for this webinar. At the end of the webinar, we will be having a question and answer session. I request all the participants to share your questions in Ask a Question bar on the login page. Now I would like to hand it over to Dr. Khalid for the webinar. Welcome once again, doctor.
Thank you very much. Hello, everyone. Our lecture today is about Cbct, which is considered as a third eye for the dentists, and sometimes as a fourth hand during the operation. Now we're going to begin our presentation. First, the Cbct history. In brief, this machine was first implemented to life in 1994 by Professor Pierluigi Mozzo et al., who developed the first Cbct machine for use in oral maxillofacial area as a part of the research made in Verona University, Italy. In 1996, the first commercially available Cbct machine with the gantry bed was available in European market. And in 2001, 20 years ago, the first Cbct machine was commercially available in USA and the rest of the world. Later, Professor Pierluigi Mozzo won the awards of the annual Science Festival in Genoa in Italy. What is the significance of having a Cbct machine or having the 3D technology? This is what I'm going to discuss now. So gonna see how such a machine or technology will differ in our dental practice. First, we have to imagine what is the benefit of having the 3 dimensions of any object. So what is the benefit of having a 3D machine in our clinic or a 3D view? First, let's imagine this house we can see this house from front view. We can imagine a certain figure of this house. But when we see from the side view, which is the missing dimension here, I can see that the house is much, much bigger than I imagined in the beginning. Similarly, we act in this imagination with dental structures. Also here I have another example. If this apple, when you see it in the mirror from one side, we can see that the apple is intact. But when we see the other dimension, we can see that part of it is missing. Also here, when you see the jar, this jar, I'm filling the jar with water, and it seems like we have a candle here. But see, the jar will be full until it reach the flame of the candle, but the candle will not stop. But if we know the third dimension, when you get the jar away in other dimension, we can see that the candle was just behind the jar. So let's find here this case. For example, I'm making implant planning, and this implant, which is arrowed right now, seems to be injuring the inferior alveolar canal. But here we can find that the canal is located buccal to the plan that we have proposed. So let's see some cases, 2D versus 3D images. This is case number 1. You can see this is an inserted implant already. This is a post-operative evaluation for the case. So you can see from the panoramic or the reformatted panoramic view that we have, the canal seems to be inside the, the implant seems to be inside the inferior alveolar canal. We make here tracing for the inferior alveolar canal. But when we see the cross-section here, we see that the implant is placed in a lingual relation to the canal, but at the same vertical level, which means that there is no direct injury to the inferior alveolar canal, although this is not the best position, of course. So when we have here this case, we can see the relation of the implant to the canal. Another case, this is a panoramic image with an implant inserted replacing the missing upper left first premolar. And this is like a zooming on it. We will find here that the implant is looking very well in the panoramic view, but it seems to be perforating the buccal plate of bone in the 3D image. So the panoramic view is always deceiving to the dental operator. So it is deceiving, and maybe we have imagination that it is laughing on you, that you misinterpreted the case. So never depend on panoramic images in all cases. There are a lot of cases we must depend on the 3D view. So here let's see how CBCT images is generated. Here we have the machine is rotating around the patient's head in 360 degrees. And during this rotation, the patient information is scanned. Let's see digitally how this can be reformatted, this 3D volume. Actually, what happens is that the machine rotates around the patient's head 360 degrees. Just consider that each degree, the machine take a capture. These captures are collected together to form what we call the Daikon data files. So on the computer, we will find that there is multiple files here. These multiple files together form the 3D volume. This file is called Daikon. So the whole Daikon dataset is reformatted by the software to generate a 3D volume. And it's very important to know about this, because when using other softwares, you must have this Daikon dataset to import it to the software that we are using. So what is the guidelines to select or use the CBCT machine? So whether you are sending to imaging centers, or if you own a CBCT machine in your clinic, how to choose which machine to buy or which imaging center to select in order to make for you the scans. Here we have some factors that alters the selection. I'm gonna get through them one after one. First is the machine detector. The machine detectors, we have two types of detectors, which are the image intensifier, which is the little bit old and not a lot of machines having this type of detector. Image intensifiers make less exposure, but it gives less dimensional accuracy and resolution. On the contrary, the other type, which is flat panel detector, it gives more exposure and gives higher resolution and dimensional accuracy. And the increase in the exposure dose is not that significant. Second factor, which is the voxel size. The voxel size, or the voxel, is the picture element for the CBCT. Same like the pixels for the digital cameras, for example. So the smaller the voxel size, or the picture element forming the image, therefore we will have images of better details and higher resolution. Structures of small sizes or that needs fine details to be revealed needs machines with less voxel size. We are talking about, for example, root canal cases. We need from a voxel size which is less than 80 microns. And the machine for the any other machine should have wider ranges that we can use, 80 microns, 70, 300, whatever. So we must have flexibility in using voxel sizes. For example, the Bondent CBCT machine has a wide range of voxel sizes from 70 microns, which is suitable for root canal cases, until 300 microns, which are suitable for large fields of view. The focal spot is a function of the image or sharpness. So most of the machines having a focal spot of 0.5 millimeter, such as the Bondent machine, but more than that will not be acceptable. Contrast resolution, or what we call the bit depth. The contrast resolution is a function that displays the different bone densities or tissues of different CBCT or CT numbers. So the higher the bit depth, the more ability for the machine to display different structure and differentiate between enamel, for example, dentine, and cementum and bone, between cortical and spongy bone. So the range that we are talking about is that we should have 14 bit depths or more, such as the Bondent CBCT have 14 bits. CBCT scan time. This is also a very important factor, that when the scan time increases, this means that we have two problems. First problem is the higher exposure dose to the patient. Second is the possibility of the patient to move within the long scan time, which can produce haziness or motion artifacts. So the scan time here, for example, if we take a Bondent as an example, we have from 8 to 24 seconds scan time according to the irradiated area. If the irradiated area is small, we will go to the 8 seconds. And if we have a large field, we will go to the 24 seconds. The patient scan position. We have two types of machines. First is the sitting position. Second is the standing position. And in the old past, the first machine that was generated in the market was like a gantry bed, but this is not available. I think nowadays is not available anymore. So what is the benefit of having a sitting position machine? The benefit here that we have is that the machine, this type of machine, is more comfortable for the patient, so less possibility of having the motion artifacts. Although the standing position machine is prepared that we can use a wheelchair or any chair to position the patient during the scan time, so we can get rid of this problem. But the standing position machines having some more benefits. Number one, there is no chair here, so the boards and the parts of the machine which cause mechanical problems is less in case of standing position machines. Also, it requires less space. Also, this is more suitable for patients on a wheelchair. In addition, in standing position machines, it is possible to place 3 imaging modalities in the same machine. We can place a panoramic sensor, cephalometric, together with the CBCT, what we call 3-in-1. But in case of sitting position machines, it is not possible to put a cephalometric arm. This is not possible. So space saving is very good in this case. So then we are speaking about the field of view. Field of view is the volume of the irradiated area. The field of view can be controlled by collimation of the CBCT X-rays to limit the radiation to a certain area of interest. So it's very important that the machine that we use to have flexible fields of view to serve for different specialties. As we mentioned in the beginning, for root canal cases, we need small fields of view like 4x4 or 5x5, not more than that. And also to be possible to scan large areas, like as we see, areas to cover both jaws, or to cover even the whole maxillofacial area if we are talking about a hospital or a government institute. The field of view, when the field of view is limited or less, become less, this means better resolution, less voxel size, and improved image quality due to less scattered radiation. We have different ranges of field of view that we classified according to the use. First, what we call localized field of view, which means that the vertical height should be 5 centimeters or less. This for the use of root canal and some periodontal problems concerned with 1 or 2, at most 2 neighboring teeth. Second is the single arch field of view, where the field of view vertically is more than 5 and can reach to 7 centimeters. This to scan one jaw, tooth-bearing area, like the mandible or the maxilla, but only the tooth-bearing area. For the mandible, we cannot say that we can reach the condyle, for example. It is only just the tooth-bearing area. Third, the inter-arch field of view, which means that we can get both the maxilla and the mandible in the same scan, but only also the tooth-bearing area, when this field of view is between 8 to 10 centimeters. Last field of view available here is the maxillofacial field of view, which the vertical height is more than 13 centimeters. In order to reach the nasion, we should scan from the soft tissue menton down until the nasion up. What is the advantage of cone-beam CT over medical CT? Because medical CT can achieve all of these 3D views. First, CBCT machines are much smaller in space than multi-slice CT or the conventional CT. And this saves a lot of money, because we can take the CBCT in one room and make a small compartment, and we can use the space for the other room. Second, the short scan time, because CBCT acquires all the projection images in single rotation, 360 degrees around the patient's head. That takes nearly between 8 and 24 seconds. But multi-slice CT, there is a lot of time, because there is multiple slices are taken around the patient's head. Also, the reduced patient dose due to the short scanning time and the less milliamperage and kilovoltage. CBCT provides doses about 76 to 98% less than conventional CT, and this also in addition to the limited field of view available to use. So beam limitation, as we said, that the dose can be limited to a small field of view. In addition, and this is the most important factor, the higher software capabilities provided for softwares coming with the CBCT machines. For example, here, and this is my favorite software, the On-Demand 3D. On-Demand 3D can make a lot of maneuvers that we're going to see in future slides. And this maneuvers is not possible to be achieved with softwares accompanying medical CT machines. So these are software capabilities. For example, correction of the head position or the occlusal plane. In CBCT, if the patient was scanned from the beginning of the scan maneuver till the end with a tilted head, for example, the software can then correct this error and then reform or reslice new cuts, which are made as if the patient was placed correctly in the machine. Here also, if the patient's head was tilted, the software can correct it and then reform the required slices. Second maneuver is the fusion and stitching. This in case that you have a machine having a small vertical field of view, so you can scan two parts separately, and then the software can fuse them together to form a single volume that covers the maxillofacial area. And this will save a lot of money because CBCT machines prices differs according mainly to the fields of view. So you can find in the same company a machine with a large field of view, which is 30% more price than the small field of view. So this software maneuver can solve such a problem. Third maneuver is segmentation. Segmentation that we can cut one part of the image and display the other part in order to reveal a hidden structure, such as in this case, a salivary gland stone. So we remove the right side of the patient in order to see the lingual part or the lingual side to check the submandibular salivary gland or salivary duct stone. The limitations of the CBCT, we have some limitations, of course. First is the higher image noise, because in this modality, there is single cone beam or cone-shaped X-ray beam that covers the patient's head, so it covers a larger area. So most catheter radiation can result from this maneuver. Second is the poor soft tissue details in relation to the multi-slice CT and, of course, to the MRI. Third is the metal artifacts has a very big influence on the image, and this is the main enemy for CBCT is the metal artifacts. So we have like radio-opaque streak artifacts and radiolucent cupping artifacts, as we see between the two neighboring implants inserted in this view. But there are algorithms and maneuvers to reduce such artifacts, and this technology is developed in some machines. From them is Bondent. They made like a new algorithm in order to correct such artifacts. The fourth limitation is the high dose compared to OPG, and as well as the high price in comparison to the OPG. And always we should have the ALARA principle that we should not violate the use of CBCT. We use it only in the places or the situations that it will add diagnostic information. So the CBCT has some clinical applications, whether in diagnostic purpose or in interceptive purpose. So first is the application of CBCT in diagnostic purpose or as a diagnostic tool. These are some examples of the diagnostic uses of CBCT, such as implant site analysis, impacted teeth, orthognathic and orthodontic evaluation, maxillofacial trauma. A lot of issues, some of them will be discussed, not all, of course, because the time will not be enough for all of these applications. But I'm going to try to show some cases. First is the implant site evaluation. For the implant site evaluation, CBCT is a must for all cases, in my opinion, and also the WHO stated that CBCT is required for all implant cases. The CBCT can add a lot of diagnostic information to the implant cases. For example, as we see here on the picture right now, we can get the true vertical dimension of bone as well as the buccal dimension of bone. Unlike the OPG or the panoramic, it is not possible to find the buccolingual dimension of the bone or any other structure, or any buccolingual position. Also, we have the maneuver of making what we call implant simulation or virtual implant planning, is to imagine the position of the future implant in relation to the neighboring teeth. And this is the first step in order to make what we call computer-guided or computer-generated surgical guides. Also, it is very important to reveal the bone anatomy. For example, in this case, we have a missing lower left first molar, and we have a vertical dimension here of 14 millimeter, which seems to be good to place an implant of 10 to 12 millimeter height of implant comfortably. But the question is, are you sure that this can be achieved comfortably? Let's see. We have a possibility that the ridge can have like a wide crest, like in the first case that appear right now, or can have a sharp knife edge ridge. This means that this is not possible. You have to go from the plateau level less than we expected. Or we can have a big lingual undercut. This means we must use shorter implants. Or we have what we call figure 8 ridge, that the ridge is wide in the middle and then is constricted near to the inferior alveolar canal. Okay, and this is another case for figure 8. So for this reason, even if we have a single missing tooth and we are seeking implant therapy, CBCT is here a must. Also here it shows the bone angulation, because it is very important info to decide our drilling direction. So if we don't have this info, are not aware of the ridge inclination, we can go in a wrong dimension or a wrong implant placement. So I can put the implant in a wrong position. Second application or second diagnostic use is the impacted teeth. By the way, surveys were made from imaging centers worldwide. What is the main reason for dentists to ask for CBCT? They found that 65% of the referred cases were referred for implant cases, and the rest of the 35 is distributed all over the other uses or purposes. So second most used purpose for CBCT is the impacted teeth. Impacted teeth, we can see here the after tracing the inferior alveolar canal, which is a feature of the software, we can see the relation of the impacted tooth, which here is highlighted in green color. We can see from the buccal side, the green color is a little bit hazy. But when we see from the lingual side, we can see that the impacted tooth here is showing very well. This means that the tooth is located lingually. And when we confirm with the colored cross-section, we can see here that the tooth is much located or extremely located lingually, which means it is away from the inferior alveolar canal, which is highlighted in red, unlike the images that we have here from buccal or lingual side. So therefore, CBCT here will interfere with the clinician decision regarding removing this impacted tooth. One of the maneuvers which is very beneficial for impacted teeth is segmentation and thresholding, that we have here from an occlusal view the impacted tooth. Here, when we remove the bone and we keep the impacted tooth, by thresholding and segmentation maneuver, we can find the exact relation between the impacted tooth and the inferior alveolar canal. This is a reported case and very interesting and very hard case. Here we have an impacted lower right third molar, and we have here like a pericoronal radiolucency, and in the same time, the canal here is passing through the root. After we make some other added views for this problem, we saw here that the canal was passing in between the two fused roots of the impacted tooth, or passing through the root of the impacted tooth. So here, this is a 3D view. We can see here exactly the canal is passing through the fused roots. Here it is very obvious. So this case is impossible to be imagined using OPG views. Another reported case for an impacted mesodens or supranumerary tooth. Here we have an impacted tooth and an impacted central incisor. So here we need to facilitate the visibility of such a case, especially if you are presenting this case to the patient or the parents of the patient. So here we have the maneuver of coloring or highlighting the mesodens with blue and the impacted central incisor in green. So here we can easily present the case and understand the case with the patient. Here we're going to discuss the CBCT and digital dentistry. CBCT here has a more role than diagnosing cases. It has a role in treatment planning. The word digital means computer. So digital dentistry means the dentistry which is guided by digital or computer generated technology. The CBCT is one of the main tools for digital dentistry, but we have a lot of other tools. So you can see here, this is the imaging machine and the periapical and the optical scanners, the camera. A lot of tools are included in such digital dentistry purposes. In digital dentistry, we have acquisition tools, or the machines which take the captures, such as CBCT, optical scanners, whether are intraoral or extraoral, or digital camera, whether they are 3D or 2D. We have planning and designing tools, which are mainly the third-party softwares. As I mentioned, one of them is the on-demand 3D when I was presenting the cases, and manufacturing tools such as milling machines and 3D printers. I'm not going to go deep into digital dentistry because this needs a lot of lectures. But I'm going to see just how the CBCT can be integrated or incorporated in such process. CBCT scans shows the bone details as well as these teeth details to some limit, unless if there is metal artifacts. Optical scanners is a function or a machine that functions to reveal the surface structures like the teeth and mucosa. So the CBCT carrying the bone information can be integrated with the scanners or intraoral scanner or extraoral scanners to make what we call the virtual patient, that the teeth, mucosa, and bone are related together using some software to virtually assemble them together and build the treatment plan. So this is the concept of virtual patient, that we can assemble scans from different machines together. The key factor here is to assemble such different structures in the same or in the correct position in order to achieve a proper alignment. The CBCT format here is Daikon, as we mentioned before, and the optical scanners are having the Stl format. The Stl format is the format which is understood by CAD/CAM and 3D printers. This is the case for me. This is my CBCT, and this is my photo, and this is my optical scans. I have an anterior open bite, and here I align them all together. This is the CBCT, and this is the optical scan, and this is my face by a process called photo wrapping. So here we're going to discuss the applications of CBCT in digital dentistry, what we call the digital clinic. Here I must be equipped with some tools, of course the dental chair, the CBCT, and the digital lab. This is the future of clinics, that should have all of these compartments in order to have the full accurate workflow. First, we're going to discuss something here, that we can convert the Daikon dataset of the patient into STL. So here, this is the Daikon display of the outer and inner bone details. In this video, I'm going to show you how we can make thresholding and convert this Daikon dataset into STL, which can be used in other uses. See here, we converted this as if it is a 3D model made with an optical scanner, but this is used using some softwares which can make STL conversion. So what is the value of having the CBCT into STL format? Some treatments, as we're going to discuss here, is mandatory to have the CBCT in STL. Like this case, for example. Here we have a cranial defect in this patient. So this cranial defect, we have here like a cranial implant was designed on the cranial defect, because you cannot design an STL file or STL structure on Daikon. You should design it on CAD software also on STL. So for this reason, here we designed the cranial implant, and then it was made in PEEK, and then it was screwed in the patient's head. Of course, the PEEK has its problems. It's not my case, but this was a treatment done for the patient. Second is the maxillofacial resection guide. This is a case also was made in our office. Here in this case, we had a lesion, we had an aminoblastoma, and this aminoblastoma was going to be resected with safety margin. So here we converted the CBCT into STL and made the design for a virtual reconstruction plate. And it was milled in order to allow the maxillofacial surgeon to place it with the screws for fixation and remove the lesion within the borders of the resection guide. Applications of CBCT also in digital dentistry, but after combining the Daikon dataset of the CBCT with the STL coming from other tools. So for computer-guided implant surgery, of course, this is a very big topic, but I'm going to just say the idea that I can import on the software, on a special software, the model together with the wax up in the opposing jaw, and having the CBCT for the same patient. And then we can, using common points here on the teeth, corresponding to we take points on the CBCT, which is corresponding to the optical scan, and then we will have the fully aligned digital patient or virtual patient. And then the surgical guide is designed according to the position of the implant inside the bone, as well as the position of the implant within the wax up. And we have the surgical guide that achieve like a prosthetic-driven implant planning. Of course, this is a very big topic, cannot be discussed in such a small time. So this is the last part of our lecture, which is the future of CBCT, or the future for CBCT. First, and there are some trials are made right now, is to implement the computer-guided root canal therapy or root canal treatment by making surgical guides that allow the endodontist to place the file in the correct position in the orifice and then continue the root canal procedure. Because CBCTs are now getting better and better regarding the resolution and the diagnostic data. So now we are approaching an era that we can have a routine computer-guided root canal treatment. Also, application of artificial intelligence and machine learning in order to achieve some diagnostic purposes. Regarding the artificial intelligence and machine learning, in the future, I expect that the CBCT machines can replace lab scanners, because we can make scanning for the models of the patient, and then after scanning this, we can convert the Daikon into STL, and this conversion is getting more accurate day after day. So I think in the future, maybe this can replace the use of extraoral scanners in clinics or maybe in dental labs in the future. Then also automatic registration between the Daikon dataset of the patient, the CBCT, and the model of the patient. And now some programs apply this automatic registration by automatic identification between the structure at the corresponding sites. Automated diagnosis, that now some programs are making trials by importing the Daikon data of the patient to the software, and the software automatically diagnoses any abnormality in the patient, such as dental caries or such as root canal problem or maxillofacial lesion, and making differential diagnosis. This is what we call machine learning, that we give the machine hundreds of cases of amyoblastoma, for example, and then the software will learn that the shape and the morphology and the appearance of amyoblastoma. So in next time, after these many cases, it will be automatically identified. And there is some software which is already evolved in the market, but it's like accuracy is still like between 65 and 70%. But I believe in the future, it will be more reliable. Thank you very much for your attending with me in the lecture, and I'll be glad to answer any questions about this lecture. Thank you very much.
Thank you, Dr. Khalid, for an insightful session. I'm sure all participants would have thoroughly enjoyed it and would have got an insight for incorporating CBCT in their dental practice. Starting with our question and answer stream, the first question is from Dr. Daikon. How accurate CBCT is while searching for any chances of missed canals in molars with obturated root canals for endodontic purpose?
Okay, so we are talking here about two problems. We are talking about on a diagnostic level or an interceptive level. So about the diagnostic level, it is accurate and reliable only if you are using the right machine with the right imaging program. So it is very beneficial, but some cases with severely constricted orifices cannot be discovered. We are talking about 20% or 15% of cases, but in general, it's getting better and better. But in the process of making guided root canal guides or computer-guided root canal guides, it is very difficult to guarantee its accuracy. It is still on the research level, but I believe some people, some doctors reached very good results with it.
So the second question that has been asked by Dr. Abdullah is how to locate missed canals.
To locate the lost canals, we should use the axial cuts. This is the best cut to be used, that we go on the cut step by step. This is the suitable slices or cuts to be used. This is, of course, after using the right technique and the right field of view and everything, as I mentioned in the beginning. And of course, having the machine with metal reduction programs, metal artifact reduction programs, because this will facilitate a lot, especially if it's a filled canal. So I think this is the way to locate it, and there is a whole lecture about locating missed canals and evaluation for root canal therapy using CBCT.
Okay. Thank you, Dr. Khalid. The next question is by Dr. Asma. What's the difference between phone beam CT and CT when you're requesting it to a radiologist?
Okay. She means the normal CT, not the CBCT, right?
I think, Doctor, she means CBCT and CT.
Okay. The difference here that when making an order form for CBCT, the referring dentist should mention exactly the area of interest that he wants and the purpose for making the CBCT, for example. So if you want to make evaluation for implant site analysis, for example, so you must mention to take the jaw of interest instead of taking the two jaws. If you are working on one side, you should mention that you are making on the right side, so you can use smaller fields of view to get benefit of higher resolution and less voxel size. If you are making root canal therapy, you should mention the purpose, because the imaging center should understand what is the proper program or maneuver to be used in order to reveal the patient's or the doctor's interest. So there should be like a coordination between the dentist and the imaging center, or the dentist and his technician in case he has the CBC in his office, in order to choose the right scan type to the right purpose.
I hope, Dr. Asma, you got your answer. Moving on to the next question by Dr. Sriram. How to identify middle alveolar artery on anterior surface of maxilla?
The same way that we identify anything. We use the axial cuts and the corrected cross-sectional cuts. Of course, I cannot reveal this right now because there are steps of reformatting the images and such stuff, but I think in next lectures we can handle this in courses. But as a broad line, we need to have the proper axial cuts to use it in all over the maxilla from the incisal edge until up, in order to locate any anatomical structure. And maybe I can put a link for you in your page of how to locate all anatomical structures. It's very nice.
That would be very helpful, Doctor. I would just like to share with you, Dr. Khalid, that a lot of participants have very positive review for the presentation, and they are thanking you a lot.
I'm the one who is thanking them for attending with me for nearly 1 hour, and I hope that after this lecture, a lot of ads can be beneficial for them in their career.
Yes, Doctor. Coming to the last question by Dr. Ibrahim. He's asking, why does he see Daikon files have less quality than when he opens the CD viewer? Is there any such difference?
I'm so sorry. Can you repeat again, please, the question?
Why I see the Daikon files have less quality than when I open the CD viewer? Is there any such difference?
Okay, I don't think there is a difference. The difference is that the computer which may be used to read the viewer, of course, is not of the same capabilities like the master computer for the main software. So I think it's a function of the computer and the display, but not regarding the Daikon. The Daikon display, if we are fixing the same software that we are using, supposed to be giving the same quality. But some softwares are giving display better than other softwares. In addition, some computers, according to the memory card and the specs of the computer, gives images display better than other computers, because imaging centers are working with like a workstation, but we are working with laptops and normal computers. So maybe this is the only difference.
Okay. Thank you, Dr. Khalid. We are receiving a lot of thank you messages from the doctors. Thank you for sharing your time and answering the queries from the participants. Also, we thank all the participants on behalf of Bondent Group for your valuable time. We will be sharing a recording of this webinar on your registered email ID. We will be showcasing our products in EDEC Dubai. Please visit our booth in Hall 2A. Dr. Adhan, commercial leader, NEA region, is going to be present over there to help you with information on endodontic and orthodontic consumables and equipment. Do visit the booth for a lot of training sessions and lectures. We hope to see you there. I would also like to request you all to like and follow our social media pages on Facebook and Instagram to make it easier for you to get information about upcoming webinars and product launches. Thank you, everyone. Once again, have a good day. Thank you, Dr. Khalid. Thank you so much.
Thank you, Dr. Sanan, and thank for everyone. And I hope we can meet soon in other lectures.
Yes, doctor. Thank you so much. Thank you, everyone.
Thank you. Bye-bye.